Hey, folks, welcome back to the show. Great episode with you today on a slightly different topic than usual. Well, they're always a little bit different, right? But what we're going to focus on today is a topic that I've heard not that much about myself, but it's definitely out there. It's called breast implant illness. And it's exactly what it sounds like. It's what a physical reaction illness that can kind of take over when breast implants go wrong. And sometimes women don't even know it's happening and only find out kind of indirectly after the fact. So anyway, our guest today is an expert in this area. But before we jump in, I just want to thank you guys for being here and encourage you to please leave us a review on whatever platform you're listening to this podcast on, be it iTunes or Spotify. If you're enjoying the episode, give us a thumbs up. And if you think that it would be of value to anyone in your life, and that goes to for you, gentlemen, if there's women in your life, particularly this episode, you think would be well served by it, please make sure that you share it out. Now, in this episode of the Biohacking Superhuman Performance Podcast with guest Dr. Rob Whitfield, we discuss the importance of reducing inflammation prior to breast implant surgery. So we're not here to talk anybody out of anything, but we are here to educate about all of the issues around breast implants. And by reducing inflammation before the surgery, you can really help to decrease the potential of breast implant illness. And Dr. Rob Whitfield's holistic recovery approach focuses on supplementation and lifestyle changes prior to, during, and after surgery. We also dive into fat transfers and the best way to have long-term success with augmentation surgery. It's important to know the signs of breast implant illness and all of the symptoms it can potentially cause. Overall, this episode offers guidance on navigating the effects of breast implant illness and how to know if your body is struggling with the symptoms and high inflammation. Dr. Whitfield is an expert at this area and gives expert advice on talking frankly with your surgeon and the importance of supplementation for proper recovery. So a little bit about Dr. Whitfield. He is a board-certified plastic surgeon with almost 1,000 breast explant surgeries under his belt. He brings a wealth of knowledge and experience to the conversation. And if you're considering breast implant surgery, struggling with breast implant illness symptoms, or just looking for more information about this important topic, then the Breast Implant Illness Podcast is the perfect resource for you, which he hosts. Now, if you want to check out Dr. Whitfield and his coming book, follow along on Instagram at Dr. Rob Whitfield or at Breast Implant Illness Expert. And you can also learn more about Dr. Whitfield's practice. He practices out of Austin, Texas, by going to his website, which is drdrobertwhitfield.com. All these links will be in the show notes, of course. And now let's jump into the episode. Hey, folks, just a quick reminder that all of the information presented in this podcast is for information purposes only. No medical advice, no diagnosing, no treatments suggested here. Before you try anything that you hear about or learn about here, make sure that you check with your medical provider. Dr. Rob Whitfield, welcome to the podcast. It's a pleasure to have you here today.
Thank you. I am coming to Austin where it is frozen like Toronto today.
Okay. You know, it's a lot colder here than it is there. Do you have heat at least in your house?
At times.
At times. Okay. Well, take it as an opportunity to check out the dark side and the cold side and appreciate the warmth when it comes back to you. Because I think I saw in your forecast, because I know a lot of people who live in Austin. I think I saw in your forecast there's a 70-degree day coming down the pipes your way. But it does appear that you're on some kind of a strange roller coaster right now.
All over the place here.
Yeah. Well, welcome to the wild and crazy world. But we're not going to talk about the weather today. We're going to talk about some really, I think, a really fascinating topic. And to some of my listeners, I mean, some of you guys may think that this is pretty niche, but I've heard from enough people in my community who are baffled by symptoms that they're experiencing that nobody seems to be able to put their finger on, and have seen on occasion them finally coming around to the possibility that maybe something that they had put into their body that they were told would be completely inert might be driving some of these issues. And And obviously, and right now I'm talking about, and we're hopefully going to, Dr. Whitfield has a broad range of topics he can address. And two of them in particular, I'm pretty keen on, but we're going to start with breast implants and how they can maybe wreak havoc with a person's system. So why don't we define first what is breast implant illness? And you were saying before the podcast that this isn't actually a formal diagnosis. Like you would not see this in any kind of textbook that people are studying in med school. So what is it and why have you become so fascinated with it?
Sure. Thanks for having me. So, for almost 30 years, I've taken care of patients, and predominantly they've been cancer patients. So the most prevalent, cancer I took care of is breast cancer. So we would do breast reconstruction. I was more of a specific provider in terms of services for that. So I would take the abdominal tissue and I would basically do a tissue transplant from the abdomen to the chest or from the thigh to the chest to create your own, basically like transplant, if you will, for breast reconstruction. And that was called autologous. It's your own tissue. Mm-hmm. And then, of course, the most recognizable form of this is an implant-based breast reconstruction, because everybody can probably have much more access to that depending on the size of their communities. I always worked at very large tertiary referral centers for cancer. And so I had a lot of access to equipment and technology and training that others, wouldn't have access to in a community-based system. But I would provide this care, and from time to time, I would have patients come to me to have their implant-based reconstruction that may have developed a problem, or they had pain or mechanical issues with capsular contractures, things like that, post-radiation treatments. And I would take it down, meaning I would take all the material out, all the scar tissue, implant material, test it all, make sure there's no cancer, make sure there's no infection, and then replace it with their own tissue. And if they had symptoms, those would resolve. So fast forward to 2016, I had a patient relocate from Atlanta to Austin, and they wanted me to take down their breast reconstruction and make them flat. They wanted no other reconstructive surgery done. And so I went through the typical consultative process, review the history and physical labs, any kind of diagnostic studies. And there was nothing on her physical exam. I fulfilled her request. She had to be taken care of in a hospital due to some other issues overnight. And at a week, I saw her, and her test results revealed no evidence of recurrent cancer, which is the number one thing that we're looking for. But on her culture results, because we would take the tissues, scar tissues out and really test them to make sure there's no contamination around the implant, she had an E. coli infection. And so this occult E. coli infection, I went back through all of my data and was trying to understand how I missed this. And I didn't have an answer. I did her consult. I looked at all the data, all the test results, all the imaging, and there was no evidence that would suggest she had an infection. So she had this occult infection. The sensitivity patterns came back to this E. coli, and I treated her with antibiotics, which I can talk about later. I don't do now, but the patient got better. They had some fatigue that resolved. And I believe she put me on a Facebook group and recommended me as a surgeon to do explants. And then people started calling our office in Austin requesting that I do their explant surgery. And I was a little concerned because, I've operated for an extremely long number of years, thousands of cases. And I can't recall in my history that I missed a implant infection case.
Mm-hmm. Does it happen often?
Implant infections? No, and yeah, I think it's very hard to understand the true incidence of an infection because from a cosmetic standpoint, many times these are not being tested in a rigorous fashion like they would be in a cancer environment. Because in a cancer environment, we are taught specific routines to follow and oncologic principles to maintain. In the cosmetic environment, you're coming in, you may have a desire to have a augmentation with or without a lift after children or whatever the scenario is. And if there's a time frame where you end up exchanging that device or something, those would be additional costs passed on to the patient. So obviously the patients and the physicians are sensitive to those costs. So fast forward to now, how I do an explant is I've transitioned from traditional techniques, which are like taking Q-tips and swabbing them and sending them off to be incubated, to PCR testing, which everybody remembers from the pandemic. It's very sensitive, uses DNA fragments. So it looks at 150 types of bacteria, fungi, and mycobacterium. And then obviously we send everything off for pathology to make sure we're not missing an underlying cancer. Because I have patients come to me who want to go flat. I have patients who are cosmetic in nature and they just want to have their implants removed along with the scar tissue intact. And we try to do that entirely each time. And we're doing that because about 30% of the time there's a biofilm. So we'll say the biofilm is not to the point where it qualifies as an infection, which is a numerical value on a high power field looking under a microscope. This is a number less than that, but when someone has a biofilm, it creates an inflammatory response in your system depending on you and how you interact with it. So every time, for the audience, you get a splinter, what happens? If you don't get it out, it gets red and irritated. So a device, a hip, knee, breast implant, dental implant, cardiac implant, spinal implant, it doesn't matter what the implant is. I've helped every single surgeon with these devices because from time to time, they'll have problems with them because they're foreign bodies. So if you just think of a breast implant over time contributing to inflammation, it goes from acute to chronic. Long-standing chronic inflammation leads to system dysfunction at every level: neurologic, cardiac, respiratory, GI, musculoskeletal, peripheral nervous system, central nervous system, etc. And then if you add in mold, or if you add in Lyme disease, or if you add in a environmental toxin exposure, and somebody who does have really limited detox pathways, now you have the perfect recipe for what I see.
So what do you see? How does it present? Like, how does breast implant illness present typically?
Yeah,
if there is a typical, because I bet you it's a whole range.
It is.
And that are getting gaslit, right, by their doctors. You're fine. There's nothing wrong with you.
Well, I think I understand both sides now because I've been stuck kind of trying to figure out both sides from my client and then from a provider side. I had, my experience with it. And then from the provider side, I've obviously been told some very strange things that I can't correlate with what, traditionally is taught. But if you just took what's called the review of systems of each system of your body, and you had a symptom that was a problem of that system, they would check virtually every box at one time or another on that list. And that's super confusing to a general doctor, a specialist, a surgeon. They're like, I don't understand what is causing this. And then if you do someone's physical exam, like I had done for my patient, and there's nothing on physical exam that, alerts you to a problem, or if they have a diagnostic study like a mammogram or ultrasound that's normal, or MRI that's normal, I mean, what do you don't really.
Yeah, it's hard to know where to go from there.
Right. So you can see the confusion, and then people are like, well, I don't really understand this as a problem. But so the root of the problem can be more simple, like your genetics, your diet, the air you breathe, the water you drink, coupled to, what are your exposures? Like, so we look at urine toxicity testing a great deal.
Right. So, okay. So, but let's go back to what are some of the symptoms that people might be experiencing? Like if a woman, I'm seeing this a little bit like there's a lot of talk about cavitations, about people who've had dental work done, or especially root canals, where you get this low grade infection, kind of inflammation that resides deep in the jawbone that is, orchestrating this whole kind of scenario. And you just mentioned, like, it can affect literally every single aspect of your health, from cardiovascular health to cognitive health to the way that your immune system functions, like all across the map. So is there a particular set of, like, do you see certain symptoms more in breast implant illness than others? Or is it really just, it could be anything just depending on this person?
The most consistent symptoms we see are neurologic things like brain fog, which is short-term memory loss. You may have light and sound sensitivity, dry eyes, A lot of people will get this kind of, you know, it's akin to eosinophilic esophagitis, but you get like this difficulty with swallowing that's really almost like allergic response. And with cardiac symptoms, it's more like racing, heart racing. Some people feel like they're having arrhythmias, but they're not. So they'll get put on monitors and not really have that problem, but they'll feel that way.
Yeah.
Shortness of breath or chest tightness is common. Muscle and joint pains, a host of GI problems, you know, swelling and bloating and constipation and diarrhea. And neurologic things are very strange. People get tremors, people get shocky pains going down their extremities.
Wow.
It's a very difficult, when you hear it, set of things, you know, from a symptom standpoint to put your finger on and go, oh, it's this.
Yeah. Yeah. And so what's the issue with the implant? Is it that the body, is it a pathogen that got embedded with it when it was put in? Or is it that it's leaking? Or is it that the body is just, at the end of the day, is like, yeah, you can say whatever you want, but you are not one of us and we do not fully accept you. Like, is it some combination of these, or it could be different things?
Well, it's always going to be recognized by the body as foreign, first and foremost. So that's always going to stimulate your immune response. The ways a device can get biofilm are somebody hands a surgeon a contaminated implant. So they contaminate it before they ever get it.
Mm-hmm.
Surgeon contaminates it, putting it in.
Yeah.
Or the third, which is the most common, is basically spread through your blood, because a hip, a knee, a breast, a dental implant are not alive. So they can't be treated like any other bacterial contaminant in your body and eradicated. So when it adheres to that surface, it creates its own biofilm, which is like a little gooey coat, if you want to think of it like that. Then your body's trying to get rid of it.
Yeah.
So it's turned on already, and now it's turned on more,
Mm-hmm.
and it still wants to get rid of it. So it's the hamster in the wheel effect. It just keeps going and going and going and going, and then you get all the symptoms of chronic inflammation. And that's how I think about it, and that's, you know, what the patients to me exhibit. And they may have gone to every fancy clinic in this country and had the discussions. And it's, I don't think, a very challenging problem when you just break it down that way. It's pretty straightforward.
And if you're willing, but at that point, is it possible to resolve the issue without removing the implant, or does the implant, bottom line, have to come out to get to that biofilm, to get, you know, you're basically, I mean, it's got to be the easiest way to go because you're physically removing.
Right. Yeah, I feel like I'm in a unique environment in Austin where there's a large integrative or functional medicine group. So I have many patients who've gone through years of treatment to try to keep themselves as healthy as possible at whatever expense. And they finally are just like, I can't keep doing this, because it'll get better for periods of time, and then it'll revert, and they won't feel well, and they won't understand why, despite leading what is a very healthy lifestyle and taking care of themselves. And this happens to be the, you know, last thing on the list that hasn't been, you know, addressed for obvious reasons, because it's a big deal. And no one really obviously wants to have surgery. No one wants to have a surgery like that. That can be aesthetically an issue. So when we do it, we offer different programming to both reduce toxicity and make people more eligible for fat transfers. I do a lot of fat transfers. That's probably one of the main things I do at the same time. So I'll take fat from other areas and transfer it. And there's a lot of things written about fat transfers that are kind of funny. So fat is the original filler. Mm-hmm. So it's autologous, but it has to heal in the position with which you place it. It belongs underneath the skin, not in the breast tissue, and typically not in the pockets, because it can't heal there. It has to, once you take it, it has to heal, obviously. And there's very elegant models to describe this, but it's really, you know, it relies on your body's ability to heal it through stem cell activation and healing in those areas. So we really work hard to help people lower inflammation, who are really, that's their intent, is to have a fat transfer. So my Holistic Accelerated Recovery Program, which we have a book coming out about shortly, helps put them into position through functional genomic testing, toxicity testing, gut health testing, hormone balancing, food sensitivity testing to really look at what opportunities there are to go ahead and reduce their inflammation, help them potentially with a period of detox before that's not too aggressive, but helps them, and then have their surgery. And then once that's done, really help them from a detox standpoint, a inflammation lowering supplement standpoint, and then surgical recovery standpoint. And I have hyperbaric oxygen in my office. I have lymphatic massage in my office. I have relight therapy in my office. So people will spend about a week to 2 weeks with us, depending on where they're coming from, just to focus on their recovery.
Mm-hmm. Oh, I would think so. So how long does a fat transfer last? Because you would, because, I mean, the interesting thing about fat is I think we underestimate it as a tissue and as an organ. Mm-hmm. It is metabolically active. It is hormonally active. Like it's a thing. It's, and we don't think of it that way. We just think of it as this inert stuff we don't want in most places.
Yeah, it's a dynamic tissue. It's a powerful tissue because it brings your own stem cells with it. So adipose-derived stem cells are mesenchymal stem cells for everybody listening, and they will not give you a breast cancer. There's been, tons of kind of disinformation about that because it can't. Breast cancers are epithelial in nature, and the cell coming from this is mesenchymal in nature. It can't. Just through its lineage, it can't give you a breast cancer. Sarcoma phalloides is the only tumor it could give, and that is an absolutely less than 1% type behavior. So I've used them, and I used to do sarcoma reconstruction and never put fat in a sarcoma defect for that reason, because it's the same cell type. So in a epithelial cancer like breast cancer is, typically the ductal cancer, that has been used for ages, to be honest. I've done it for patients since 2002.
Wow. So how long does a fat transplant last?
So it's like longevity, right? I think I use the example of, like, if you're in your 30s and we do a fat transfer for augmentation, or someone does a buttock augmentation, it heals and it lasts. And as you metabolically change, things change. That's more to the point. As hormone changes happen and metabolism changes happen, thyroid changes happen, that's when I see variance in results, because people's weight will adjust over time. Some people lose weight when they get older. Some people gain a bunch of weight when they get older. So the fat will just go along with whatever's happening, basically.
Oh, so if you start losing fat and you've done all this work and had this fat transfer, it could be counterproductive with respect to that one goal of the fat.
Obviously we'll just talk about the GLP-1 inhibitor.
The elephant in the room. Yeah.
Get called about this a lot. And so just for everybody, who's listening, it's best to ask me before you do that after surgery. So the short answer is, if I'm doing a very elaborate fat transfer for you, we don't want you to go home and see your practitioner and get placed on a GLP-1 like Ozempic, just because that's going to affect what we're trying to do for you. So we help people with as much guidance, counseling about that as possible, but it's best to always discuss that, whether it's me or someone else helping you with things like fat transfer, because we're taking a metabolically active tissue and we don't want to do things to undo it as it heals.
Yeah. But once it's healed, it still will be subject to all of the metabolic influences in the body that affect fat. So it doesn't matter if it's 2 weeks after the fact or 2 years after a fact. Whatever you're doing to your body that affects your adipose tissue is going to affect that adipose tissue too. It's not
certainly can.
It's not isolated out of the system, as it were.
No, it's your tissue. That's why it works so well. So in this environment where I've got people losing weight all of a sudden at large amounts of it, even after I do things, I feel like we just have to have a discussion about, if you're considering that, you just tell me and I'll tell you, no, that's not something you want to do right now. Or, okay, if you're going to do it in this manner, and we'll pause what, our treatment plan will be for you.
Cool. So let's say a woman has breast implants, and she's not feeling particularly awful. I mean, she feels fine, right? That four-letter F word, fine. She feels fine. She's concerned about her longevity and health span. She's like, I'm. What are the odds, in your experience, that those implants are running counter they're running counter to her long-term goals? So she doesn't have like severe issues going on. She's not walking around thinking she's losing her mind at this point. She doesn't have massive inflammation that she can tell. At what point would you say, like, how much of an impact do you think the implants have on that whole system homeostasis, if you will? Because I think one of the interesting things about humans is we can adapt to a lot of different weird things, right? And as a practitioner myself, like when I start working with people, very often they don't realize how crummy they feel until they feel better, because we normalize feeling not great. We're just like, I'm fine. Like I can get through my day. I can do this. I can do that. I can get through most of the things I need to get done. So, but I think I heard you say in another interview that about 30% of women will be, and I could be wrong about this. I thought I heard you say that about 30% of implants will be maybe an issue for people. And is that purely dependent? Well, no, it's probably somewhat dependent on genetics and somewhat dependent on whether some nasty bug got in during the surgery. Is that
right? So hopefully here in the next couple months, we'll have our experience published. So about 30% of our consecutively tested samples since 2019, I think it includes over 900 samples, the rate of biofilm is 30%. So how it got there, once again, we discussed the three options. Most of what I think is going on, honestly, is not at the time in the OR. It's just life in general. So someone gets a cut, or someone gets a cold, or someone gets urinary tract, whatever the case may be, you get hematogenous spread, and then that interacts and creates, the contamination. And then if it's a bacteria that helps really produce biofilm like Cutibacterium acnes, then it's even more of a problem for your body. So in terms of, what people will experience this, I've done a host of tests, and I don't have one just to hang my hat on to tell us how much inflammation you're experiencing. So whether it's when I do a no-cut facelift or I do an explant for breast implant illness, everybody has a baseline. Mm-hmm. Then I know we can drop it through support of their pathways for immunity through supplementation and identifying other risk factors and modifications of their diet. So no one has the one thing that can tell you like, okay, it's at this level, and if we do these things, it will drop. The things that people look at in blood work, SED rate, CRP, are not very helpful in our patient population. So you don't hang your hat on that. Mm-hmm. I've looked at other markers, thromboxane A2 derivatives in the urine, and the problem is it's not sensitive or specific enough to give you the information to then follow longitudinally. So I know from start to finish, predominantly all the patients, I can drop their inflammation once we look at all the factors, especially their tox reports. Because if I do an explant, but I don't know you have mold, or I do an explant, I don't know you have a triclosan exposure or a phthalate exposure or another environmental toxin, and that's just going to sit there. So it's you don't know 100% of the things you don't look for. So mm-hmm. If you identify those factors, I think then you can actually pave the way for the patient to do better from an inflammatory standpoint. But when people stay swollen, stay fatigued, that used to bother me a lot. I feel now we're lessening the pool of people who can experience that by just being very, careful as much as we can on the front end to identify, okay, what else is stimulating the system? And once you know that, people are like, oh my gosh, I didn't know that. Or, maybe they live in a certain place and that's got a bad, air quality because of the industry around it or what they're building around it or whatever. Like, you never know what's going on with people. So I have people come from all over the country and now out of Europe, and you can imagine I'm seeing quite a few interesting things that I had no idea, and if we don't counsel and express this back to them so they can go back to their environments and try to work it out, it's going to dog them even after surgery. So the surgery is a component, of course, but making sure that you can manage these exposures and decrease your toxicity to a point where you feel better. I mean, we can go into long discussions about me and mold. I actually went and got plasmapheresis recently just because I've had difficult, issues with mold toxicity in my own life.
Interesting. Well, it's so prevalent at this point, right? And if it's not one kind of mold, it's another. I think, there was a time when people were like, oh yeah, well, all you have to do is go live somewhere that's not damp and you're safe from mold. And it's like, actually, mold is one of those organisms that's super creative and adaptable, and it lives in Arizona. It's just a different kind of mold. Like, it's just, mold is mold. So where do you begin? Like, do you begin with the testing, or do you begin with the genetics, or those are like kind of hand in hand, both pieces of the puzzle that you have to look at initially, like right out of the gate kind of thing? Because, there's this whole concept of your bucket, right? How full is your bucket? And you get sick when your bucket overflows. And it would seem to me at this point that any foreign body you introduce into the body automatically, raises that bucket a little bit, and how much, depending on, as you're saying, the terrain you're introducing it into. So do you already have Lyme, mold, EBV, like other kind of, or environmental toxic exposures that your body's already trying to deal with? Or is it and it could be an or, are your detoxification pathways right out of the gate, just because of your genetic predispositions, kind of not optimized? And so now you've got two things going on at the same time.
Yeah, my curiosity has always been about genetics. So I'm looking for clients who are supremely committed to understanding everything about the problem. And it's not just a surgical problem. If you think it is, then at the end of the day, you're going to be not happy by the outcome. So everything for my recovery program is rooted in your genomics. So your genotype, what are your detox pathways, which you're alluding to? Everybody has them. And they work at a certain level. This group of patients has pretty limited detox. That's why they become so symptomatic.
Typically.
So then you look at their exposures in their gut health and their food sensitivities and your hormone balance. Like, a lot of people have really suppressed thyroid function or sex hormone function. So when you look at all of it, and we do that on the front end. So testing is integral. We have an inflammation support bundle. And I know everybody's like, oh, I take too many supplements. All right, I don't want to hear her. That problem is, there's pill fatigue. So most of ours are liquid liposomal formulations. Frequency, most of them are once a day. And, they're not that many, and they're super specific to genetic pathways. So I'm trying to augment somebody who has pretty limited detox, pretty poor absorption, and in the most efficient way possible prior to surgery, so we can help them through surgery. So I don't stop supplements during surgery. Mine are formulated to not expose the patient to undue risk from bleeding by having too many of one form of supplement in them. So I just continue them. And then we use CellCore before and after surgery for detox. So we're trying to really give a well-rounded approach to it in a supervised manner as possible.
Yeah, well, that makes a lot of sense. I've often believed that this whole blanket stop all supplements, I don't know, what is it, like a week or 4 days or 5 days before surgery, 2 weeks before surgery, mostly is because people, the health professionals in question can't, first of all, people are really bad at telling people what they're taking. That's for starters. And then the second one is that the health providers, depending on their training, don't have the time or the knowledge necessarily to sit there and go through every one of the supplements and decide what's going to work for you, what's going to work against you. So they've just issued this blanket statement, stop everything.
Yeah, it's basically, the herbal supplements are unregulated, so you don't know the quantities of anything. So you have to not be taking those. So for my patients or potential patients, you're taking mine and mine only. You're not taking other things from other providers. You're not taking things from Sprout or the, online stores, because if you have, say, too much ginkgo in something, you're going to basically anticoagulate yourself and bleed.
Yeah,
So the reason providers do it is, one, they want to be safe in every situation. And
absolutely.
two, you have to be, in my practice, we're very specific about what we're talking about.
Hmm.
So you're using ours, not theirs. And these are the formulations, and this is why. So we've just, taken that upon ourselves because it helps. I don't want anybody to stop a couple weeks out when they're doing better and then go through the process where they have surgery and then they got to recover and then they got to resume, and it's already complicated enough. So
Yeah, for sure. Um, so basically you're offering really a full, well, we could call this a holistic approach. Like you're looking at every single piece of the puzzle, both before, during, and after the resolution of the breast implants. And so have you seen, like, do the dental issues coexist here, do you think?
yeah, our patient populations are very similar and they're very sensitive to that. And they ask me, what to do this first or do that first. And I don't have a specific, like, got to do this in this order. So the breast implant's a pretty large device if you think about it. So
For the
if
body, yeah.
yeah,
Yeah.
if you think of it just as, if there's a proportion, dynamic to it, then I say, this is a much larger device. Um, I don't, have enough kind of overall like to like patients to compare, like, did they do this and have a better outcome? I don't have that information at all. I just have patients go like, I'm doing this first with you, and then I'm going to go to the biologic dentist, or I've already went to the biologic dentist, and now I'm with you because we're just taking things off the list that are potentially a
Yeah.
problem. And my patients at this point are super selective because they want to follow a holistic accelerated recovery program like I have, and they want, that's a big attraction, for us because we try to be extremely detail oriented in what we're doing.
Yeah, no, I love it. I think it's great. I think that's so amazing. And so you have a book coming out, and it outlines really your program. And you were saying before that we started recording the podcast that you have a goal in mind here. Like you have your vision is not just to do more surgeries and treat more patients. You have a much bigger vision, which is great because I think, once you get to a certain level of mastery at your craft, which isn't to say that you're not going to keep learning, and you learn something every day and all that, but you're only one guy, and you do have this kind of greater vision of sharing a lot of what you've learned with other practitioners and surgeons. Do you want to talk about that a little bit? Because,
Right.
it doesn't seem to me like this is necessarily particularly commonplace. So,
Well, I feel like, you know, you want to provide as much value as possible. So the value for us will be getting our book published about holistic accelerated recovery with some nuances, providing new insights and therapies and peptides and stem cells and functional genomics, along with pharmacodynamic testing for your genome. So I think, computing caught up, and I was in med school before the internet became a thing. So before Google, I was alive and in med school. And I think now people type things into Google for answers. Fair, it's fair, but it's okay. It's like using AI. If you don't know the prompt, how are you going to get the correct answer?
exactly.
So when I, think about this now, I serve a lot of audiences, not just my client audience. So I have people who they have no idea what this problem is, and they're just looking for an answer.
Mm-hmm.
And so I have a show, and we have a book coming out, and we'll have another book coming out. So we have that group who's just clamoring for some kind of information. And then we have obviously patients of ours and of others, and they want more information about recovery because, like you said, not everybody's going to offer what I offer regarding recovery.
Mm-hmm.
And then I really want to help the providers because I think they're trying to help patients, but they don't know or understand what's going on. So it could be an acupuncturist, a naturopath, a MD, ND, DO, MP, or NP, PA. It could be anybody just trying to help, health coach, but they don't know how best to help. So we want to serve those audiences because they're all important audiences.
Mm-hmm.
And then surgeons who want to understand what I'm talking about and engage in it and learn more about it. I think the biggest thing is I want to help anybody curious about it because I was super curious about it. And that's what led to what I did. Everybody's like, why do you do all this? I'm like, I don't ever like missing things. I don't like not understanding things. The people who trained me were very talented, and they encouraged me to always remain curious about what's going on, not settle for an answer if that's not the right answer. And I feel that's the most important thing. Is I have a pretty large amount of experience and evidence to support what we're discussing in a way that makes sense. I think when you fundamentally think about it. So as much as we can do to help, we want to do that.
Yeah, I love it. Now, for this audience in particular, you said a word that is the magic word here. And that's the P word, the peptide word. You mentioned that you possibly incorporate those in your protocols. Do you want to talk about that a little bit? Are you using peptides kind of as a healing modality, or in helping the immune system behave a little bit better, or?
Well, I'm always getting in trouble for something I say, so I might as well just throw this out there. So obviously peptides are useful. Recently, the FDA became a little critical of peptide use. So currently, we're just kind of on hold in our practice because I don't know what they're going to do, much like with stem cell discussions. I just, it's a bit confusing to me. I know they're trying to regulate things, and I hope they always take the position of safety, which is the goal. But I don't find peptide therapy to be an unsafe, part of practice. And I've experienced peptide therapy myself and stem cell therapy myself. So I would never put a patient through a process or program or therapy that I couldn't experience. Obviously, I can't experience different surgeries, but I've had 5 knee surgeries and an Achilles tear. So if anybody thinks I'm inexperienced about having surgery, I've had knee.
Yeah. That's a nasty one.
Yeah, peptide therapy, BPC 157 for just recovery or GHK. I mean, there's lots of really useful ones. I try to be careful with our patients and what we prioritize, which is their diet first and foremost, and their air and water quality. And I try to keep it simple with supplementation. So I've really limited peptide therapy even before the whole position by the FDA, just because I need an extreme amount of compliance with a program. I have outliers when people cannot follow the program. So if I make the programs too complicated, then I'll have a difficult time. And peptide therapy, for everybody listen, is very specific. Some are daily. Most of them are injectable. And I want to keep it really simple in recovery. So I typically don't include those in all my plans. And then now, because of the position of the FDA, we've just paused what we were doing. There's lots of therapies that are going to play larger and larger roles over time, and that's one I think for sure.
Yeah. No, I've had some experience. I actually had I've talked about this before. I had a small surgical procedure on my chest, and every plastic surgeon I spoke to said it will scar. You will have a really bad scar. And so I put it off. Finally, I'm like, okay, the hell with it. I'm doing it. Like, I had this cyst growing, and it was like turning into a third organ. I was like, okay, this is not okay. I'll deal with the scar. Like, I actually fell off my paddleboard and exploded it, and then the damn thing came back. It was awful. Anyway, but by using peptides, and I actually use a few of them topically. Yeah. I mean, if you looked very closely, there's a hairline imperfection in the skin, but you can't call it a scar.
I mean, we'll put it in my book, and I'll have to put the disclaimer in there. This is, we feel these are the peptides that are available currently, and they can help, but you have to obviously approach it with a disclaimer. It depends on where you are in the world, whether or not these are going to be available to you. And just like stem cell therapy, I mean, it's what it is right now.
So it's interesting what you said earlier about the adipose tissue, because it comes with its own stem cells. And so does that inherently facilitate healing of itself, like just by the fact that you're bringing new stem cells into the area?
Yeah. Principally, that's why it works.
Yeah. That's pretty amazing. So I just wanted to touch on another area that you work in, which is this whole facial rejuvenation space, which is very different than giving people facelifts. I mean, facial rejuvenation could be a facelift, but you have a very different approach to it. And so I just thought, for the audience that is interested in it, maybe we could touch on that a little bit before we move on.
Sure. I think, and we talked about it before the show a little bit, I really am interested in natural results. I think we have a lot of unnatural appearing people. If you watch an award show, you'll notice them. You may notice them at your holiday dinners, depending on where you are. So, we want to always promote a natural appearance. And so I've trademarked something called the no-cut facelift, where we take skin and remove it without leaving a scar. We tighten necks, and we enhance deeper tightening of the cheek tissue and neck tissue just through different energy modalities or through different devices. And it's all meant to be a minimally invasive way to make an improvement, to make a change, and not leave you with a visible scar. So I don't feel like in this day and age, I can really support like big tummy tuck scars or facial scars to get a result when we have, things that provide tightening through energy, like radio frequency, or if we can do a minimally invasive neck lift, my Zoom lift, or if we can do a skin removal that doesn't leave a scar with a microcoring device. And so when we put all those together, that's really my no-cut facelift. And we, traditionally will provide growth factors, whether it's a stem cell therapy or an exosome treatment, or, prior to the FDA's position on peptide therapy. So there's lots of things that you can do to enhance the appearance without basically having a traditional facelift, which I don't do anymore. I concentrate on these procedures that I feel like make sense, and I run my program around lowering their inflammation prior to either a breast or a face procedure. So those are the two things I concentrate on. And I hope that as we get further and further along in this decade, that more and more technology arrives that will allow me to be a bit more flexible with this, so I can do it throughout a number of different groups of patients of different skin types and ages. And currently, I can organize plans for patients, but the problem with anything is the patient keeps changing on me.
So what's the best patient for the type of interventions that you practice? Because you were saying to me earlier that, you have to have a certain amount of elasticity still in the skin.
Right.
Or, if your skin, if the skin's sagging and doesn't have that rebound, you're going to struggle to get the results.
It's an interesting, this is where it pays a little bit to have me as your provider, because I can examine you and tell you that. But in general, past 30, 35 years old, our collagen and elastin goes down, the content on our skin. And that's what gives us the, tightness and quality. And I've done this on folks in their mid to late 30s, 40s, 50s, 60s. And the preference is younger versus older because the content of the collagen and elastin is higher.
Right.
And so, if you're thinking of the bell-shaped curve, you don't want to be on the other end of that curve. You want to be closer to the front, and that will help me get you a more impactful result. It's all going to help, but the issue is how much and where you're starting from. I guess it's always that for me. Like, at what point do I have to start you? Like, if have someone come in and they've decided they're going to get their face done, they've come to that conclusion, they'll come see me, and I'm probably somebody's worst nightmare like that, because I have no problem with telling you no.
Yeah. Yeah.
So I'll tell you, like, yeah, I think you need to run this program because of the way you eat, you drink, all these things affect you. And if I don't perceive you as someone who's really committed to the process, you're not going to be a client of mine.
Yeah. Well, they're not going to reflect. I mean, they're not going to get the results. They're not going to get happy, A. And, it's not going to be a great reflection of your work, B. But so can a 60-year-old have success with these procedures?
Yeah, you can. You'll have to do more of the microcoring portion of it because the skin lacks.
Really unpleasant. The microcoring. Is it that my imagination or what would, like, how micro? Like nano micro?
0.5 millimeters. So if you've had microneedling, it's a poke hole, right? A little puncture, and that heals and produces collagen. So that's nice. This is removal. So it's a microneedle that's hollow and has a 0.5 millimeter head. And so it's taking tissue out. So in areas of concern like the cheek or the jowl area, works really well. Those are the FDA approved areas. You can do in the trial they did sessions. They did 3. So it depends on where you start, but it's something that you could build a treatment plan for that you could do on a annual or every couple years or whatever you decide. Like, once again, it goes back to picking your parents and how you eat and how you live and how you're aging. So if someone has a really, set up to have a high inflammation, program, they're going to age faster. And so I can't stop that completely with a facial aging treatment. So if that person's very committed to a one stand, draw a line in the sand type treatment, that's going to be a open facelift. So,
right.
But people age out of those as well. It's not like those magically are the end all be all. Otherwise, I wouldn't get asked to revise so many of them.
Right. Well, they don't freeze you in time, right? They'll pull you back, and then you're going to kind of age from there. So for these techniques that you're talking about, again, what you're doing is you're driving rejuvenation at the skin level. You're not really moving things around in the same way as a facelift, where you're going to cut and lift and move things.
Right.
So you're going to end up with interesting.
It's one of the few things that changes texture. I think a lot of people I've heard on different programs in your world talk about the skin and how aggressive treatments are. I don't laser skin anymore. I haven't for many, many years because I feel it's a controlled burn of the skin is a very, it's not the injury I'm trying to get. It's more that I'm trying to create an environment to lay down as much collagen and elastin. And there's methods that make more sense to me over 30 years than others. So I prefer something like microneedling, microcoring versus lasering, which is very aggressive and ablative. Lasering especially creates a controlled burn, and that's why it works, obviously. But it also can make skin more fragile. So I like these types of minimally invasive techniques that kind of, create an injury. Just like if you were to go and get an IV, within a day or two after the IV, you can't see where you had it unless you're bruised because your body heals it and it's gone. So working on that premise, if you take these smaller microneedling, you kind of see where the concept goes. That if you're under 0.5 millimeters, nothing scars because it's too small to be visualized.
Okay, so that was going to be my next question. Is there a risk of scarring in people that don't, because people do heal differently, right? Different people, right. You get the people that form keloid scars and...
That's the cutoff.
Right, yeah.
So if you're up to 1 millimeter, you're going to see it. So if someone's getting a hair transplant, they use a 1 millimeter diameter punch. that in itself creates a visible scar. So when you're working under 0.5 millimeters for this, which is to remove skin and help tighten it, you won't create a scar. And you can do up to, oh gosh, I think the most I've done on a face is a little over 26,000 cores, which is about 1.5 square inches of removal.
That sounds painful. But I mean, if it's like microneedling, it's not as bad as it sounds, really.
It's all under local. I've done all of my traditional facelifting, this minimally invasive treatment, radiofrequency treatments, and my no-cut facelift under local now, really since the pandemic.
Okay. Yeah, that makes total sense. Okay, well, let's tell people about where they can find you and learn more about you and be the first to get their hands on your book when it comes out, because it's coming out imminently, right? Next month or so?
Yes. Yeah, they're cracking the whip on me. So
yeah, chop, chop.
So for breast implant illness, we have several channels. Breastimplantillnessexpert.com is the URL, and then at breast implant illness expert, and then on YouTube at breast implant illness expert. And then for the cosmetic treatments, where you're just looking to learn a bit more about the rejuvenation that we spoke about, the no-cut facelift, we have drrobertwhitfield.com, drrobertwhitfield.com as a URL. And similarly on Instagram and YouTube, you'll find that. And I have 2 shows, one about breast implant illness and one about cosmetic surgery. You can just follow. And I try to give as much information in a easily digestible manner as possible.
Well, I've been to your YouTube channel. It's fantastic because a lot of your videos are quite short. So it's bite-sized pieces. It really, you do a good job of breaking it down for people. So so you have 2 different podcasts, 2 different shows where you produce content? Okay. So what are the names clearly of each?
Implant Illness with Dr. Robert Whitfield.
Yeah.
And Dr. Rob's Solutions with Dr. Robert Whitfield.
Okay, and that's on Spotify, Apple, all the normal channels.
Until I get kicked off again, yes. Why
did you get kicked off? How could you possibly get kicked off?
I'm always getting in trouble for something, to be honest.
That's a gift. Good for you. Means you're doing something right. All right. Well, Dr. Whitfield, thank you so much for being here today. I really appreciate your time. I'm looking forward to, I don't know, let's do a follow-up when your second book comes out. I think I do love your approach. I love this kind of holistic, full body approach. It's unfortunately not out there enough. And it's nice to see that people are taking note. And I'm sure the results that you get with people speak for themselves.
Well, I appreciate you having me on, and I look forward to visiting with you again soon.
Thank you.